I'd like to invite Dr. Doug Brockmeyer to come up and speak about craniocervical junction challenges and how they change with age.
Thanks. My name is Doug Brockmeyer from the University of Utah. I first want to thank Dr. Bisson and the organizing committee for the invitation to speak this morning. So we'll head north to the Craniocervical Junction and talk about challenges there and how they change with age. So why am I giving this talk? And I've been practicing neurosurgery for 34 years. For 23 years, I did all pediatric neurosurgery. And then for 10 years, I had a hybrid practice with adults and pediatrics. And then for the last year, I've been doing strictly adults. I've taken care of patients from newborn age to 70 years of age, especially focusing on the craniocervical junction. So hopefully you'll get something from this talk. So common conditions by age group in kids, Chiari malformation by far number one. Congenital abnormalities, very, very common as well. Trauma is obviously location dependent in some ways, and then tumors occur occasionally as well. For adults, other more complex issues come in. Hypermobile EDS, again, Chiari malformations, idiopathic intracranial hypertension, spontaneous intracranial hypotension, of course, degenerative disease, and again, trauma and tumors. So here's some examples of pathology. So, wow, unfortunately, none of my images came up. That's unfortunate, but so Chiari malformations, vertebral anomalies, AO dislocation, and tumors. So for the evaluation at the craniocervical junction, we know a lot about it, and we would address deformity issues in the various planes, sagittal, coronal, and rotational planes. We know a lot about the instability and the thresholds that are required to require surgery at C1, C2 with distraction or translation, same thing at occiput C1, and we have ways to fix these conditions either before or after or during surgery. The pediatric spine is more flexible. Kids that come in and have basilar invagination, place them into preoperative halogravity traction is very important, and that's a good tool to use. So for the pediatric patients, I'd break them into three categories: patients with normal anatomy, trisomy 21, or trauma. Abnormal anatomy and skeletal dysplasias, you're mixing and matching fixation points around the craniocervical junction with a variety of skeletal dysplasias, clipophile, mucopolysaccharidoses, et cetera. And then there are patients who have structural lack of bone with status post Chiari malformations or tumors that you need to bridge the craniocervical junction and potentially go down a little bit further. So for C1, C2, the same principles apply for adults and kids. I'm a big fan of the transarticular screw, and I had pictures of these here, and you'll have to imagine a transarticular screw on the left and a Harms construct on the right. So for adults, hypermobile EDS, idiopathic intracranial hypertension, and spontaneous hypotension, a big part of this patient age group. Less frequent Chiari malformations, believe it or not. And you need to involve multiple specialties. So a neurosurgical person involved with expert in spine, and then interventional radiology is extremely important to work with patients with IIH. You need your neuroradiologist, neuro-ophthalmology, headache neurology, dysautonomia, and physical therapy are all extremely important members of the team. So for adults, they present with headaches. They come in, you have to sort out. People can have 2 or 3 or 4 different types of headaches, and they can overlap. Sorting that out and figuring that out is really important. Tonsillar ectopia is common, but it doesn't necessarily mean that people need surgery. If a young, slender female walks into the office and they're complaining of head and neck pain, you're going to immediately think about hypermobile EDS. Comorbid conditions are common, as everybody knows. Sorting out the precise reason the patient is symptomatic can be challenging, but it's very, very rewarding, and you need to engage your colleagues. So here are some examples. Again, so we're talking about hypermobility. So I use dynamic CT scans, inflection and extension rotational views. If the BAI changes, if the net change is 4 millimeters or more, That's suggestive of hypermobility at OC1. At C1, C2, rotational hypermobility more than 41 degrees is my threshold. If there was a woman who came in with tonsillar herniation and eccentric syrinx with pain and numbness in her upper extremity and an empty cella, you got to get to work. You got to rule out IIH. You got to figure out, is Chiari driving this or IIH, and exactly what's going on. So again, adults that come in with severe craniocervical kyphosis, assimilation of the axis, bulbar myelopathy, scoliosis, and syrinxes are fairly uncommon. I've only seen one patient. I've seen many, many patients over the last 10 years. Only one of them has come in like this at around 50 years of age. Again, osteodontoideum chordoma certainly happen. So for conclusions, all age groups have their challenges. For pediatrics, obviously size, vertebral anomalies, and growth are major challenges. In adults, it shifts, more complex presentations, comorbidities, and they have previous treatments, previous surgeries sometimes. And, it's always advisable to consult with your colleagues, but when you're taking care of these adult patients, it's mandatory that you create a multidisciplinary team during the treatment of these pathologies. So thanks for your attention.